All right, everyone, welcome to my presentation. My name is Dr. Joshua John Curry. This presentation will focus on cannabinoids, natural and synthetic, cannabis use disorders, and cross-addiction related matters as they correlate with cannabis use and cannabis abuse. Cannabis is perhaps one of the more recognizable and misappropriated cannabinoids throughout the world, providing abusers with euphoria similar to the abuse of depressants, central nervous system psychostimulants, and even hallucinogens. Cannabis has approximately 4 to 10 times the amount of the carcinogenic substance found in cigarettes. And when it comes to cannabis use, which could lead to abuse, there is the likelihood of an individual or an abuser developing iatrogenic dependence. That's the physiological, physical, and psychological dependency upon the chemical. Throughout the world, there are specific geographical areas in which have gone through the legalization slash decriminalization of cannabis, and this is for predominantly medical, psychiatric, mental health reasons. Despite that, people still find ways to take advantage of these processes for abuse or misappropriation processes, which I'll get into later in this presentation. When it comes to cannabis use disorders from a clinical perspective, the 5th edition of the Diagnostic and Statistical Manual of Mental Disorders substantiates that the misappropriation of cannabis constitutes as an actual diagnosable mental health disorder. An example of that would be the individual presenting with a cannabis use disorder mild and early remission diagnosis. And whether it's a mild, moderate, or severe diagnosis, that of course depends upon a severity index that's utilized during a drug and alcohol screening for the presence of an actual substance use disorder diagnosis. Whenever there is an unspecified specialization that's connected with specific substance use disorder, such as in this case we have a cannabis use disorder unspecified diagnosis, the screening that was administered ascertained that the individual is presenting with some sort of cannabis use disorder, but based upon their responses, it could be a little bit challenging, at least in the setting or during that particular circumstance, for the screener or the practitioner to make an accurate assessment or determination of whether or not the individual is presenting with a mild, moderate, or severe diagnosis, or if there's some other some sort of specifiers or some sort of additional morbidity or health-related matters that can make this determination a little more challenging. But despite all of that, this person is still presenting with some sort of cannabis use disorder diagnosis. So in this particular case, at least for the time being, this is when it's appropriate, according to the 5th edition of the Diagnostic and Statistical Manual of Mental Disorders, to add the unspecified specification to this particular substance use disorder diagnosis. The detrimental bearing on the respiratory system stemming from consuming even a small amount of cannabis is proportionate to consuming up to roughly 15 cigarettes at the same time. We have to recognize that marijuana contains a chemical called benzopyrene, which is a substantiated cancer-inducing agent. Unfiltered marijuana smoke is drawn into the lungs during marijuana use or abuse at a temperature hotter than cigarette smoke, and this ultimately manufactures the dehydration and irritation of lung tissues, which subsequently leads to those respiratory challenges that could cause temporary or even permanent morbidity-related issues. Individuals with complications corresponding with cannabinoids and chemically synthetic compounds demonstrate characteristics of cannabis use disorders. Cannabinoids are substances which are derived from the cannabis plant. When the upper leaves, tops, and stems of cannabis plants are extracted, dehydrated, and cylindered, the product is referred to as marijuana. wanted to bring our attention to gender-related matters as far as cannabis plants. Male cannabis plants have 5 leaflets on each of the plants, while female cannabis plants have 7 or more leaflets on their respective plants. A moderate accumulation of a chemical compound referred to as tetrahydrocannabinol. And tetrahydrocannabinol is what the acronym THC stands for. Tetrahydrocannabinol is found within male and female cannabis plants. Directing our attention to urine analyses, whenever we take a urine analysis, whether that's for employment, child protective services, the criminal justice system, those respective examinations are testing for elevated nanogram per milliliter levels of tetrahydrocannabinol. I would like for us to understand that our bodies actually produce tetrahydrocannabinol naturally. It's very small quantities as far as nanograms per milliliter. When we inhale or ingest or chew, however we get tetrahydrocannabinol into our system, what happens there is our nanogram per milliliter levels elevate. And let's just say a respective examination is testing for up to 150 nanograms per milliliters of tetrahydrocannabinol. If we engage in some form of recreational or illicit substance abuse as far as cannabis, or in this case marijuana, our tetrahydrocannabinol nanogram per milliliter levels will elevate in most cases beyond that 150 nanogram per milliliter threshold, and that's how we produce positive urine screens when it comes to those particular circumstances. So even if we inhale or smoke just a small quantity, or what we feel as though is a small quantity, and we're going to get into that a little later as far as the determination of quantities that we're putting into our bodies, we could still progress beyond that particular threshold to have that urine analysis results depict being a positive screening or substantiation of recent cannabis abuse. Remaining on the subject of tetrahydrocannabinol levels being elevated as far as nanograms per milliliters when it comes to urine analyses or urine screenings, other ways to do that is through hashish. And regardless of the way cannabinoids are ingested or introduced to an individual's body, cannabinoids are customarily smoked, but may perhaps be consumed orally, being mixed with food and beverage products. So there are multiple ways to have cannabinoids introduced into our systems. The cannabinoid in which has been identified as predominantly accountable for the psychiatric euphoric effects of cannabis is referred to as delta-9 tetrahydrocannabinol. And later in this presentation, I'm going to discuss the differences between delta-9 tetrahydrocannabinol in comparison to what's referred to as delta-8 tetrahydrocannabinol. At this particular point, I want to focus on delta-9 tetrahydrocannabinol. Cannabis being extracted from the cannabis plant doesn't go through a scientific or medicinal purification process. It's extracted from the cannabis plant for illicit, abuse-related, criminogenic-related reasons. Without it going through those particular purification processes, that's where the euphoria comes from. Delta-9 tetrahydrocannabinol is generally what's being extracted or manufactured in some particular manner and distributed, for illicit reason, and that's what's sold in the street. So if we've ever known anyone, or we've done it ourselves, went out and purchased cannabis from the streets, we may have perhaps, there's a good chance that we were purchasing cannabis that had delta-9 tetrahydrocannabinol in it, and that's what caused us to go through those euphoric belts that we were experiencing. The tetrahydrocannabinol content of illicit marijuana has increased significantly since the middle of the 20th century to as much as approximately 15%. Synthetic tetrahydrocannabinol has been utilized for specific medical conditions, such as for nausea and vomiting induced by chemotherapy. It has also been instrumental regarding treatment for anorexia and considerable weight loss in individuals with acquired immunodeficiency syndrome. Now, even though synthetic tetrahydrocannabinol has been used for medicinal scientific purposes, it's also been used more prominently recently for illicit reasons. I'm going to dive into that a little later in this presentation, but I did want to touch on at this particular point that with synthetic tetrahydrocannabinol being out there in the streets, individuals are either on purpose or unassumingly, in this case I would say smoking. Individuals are smoking what they believe is marijuana with not having that understanding of what they're actually consuming is a chemical product that's synthetic or been modified in some particular sense. They have no idea, or the people they're around, if they're around others, they have no idea of the adverse reactions that they could be facing, whether that be within a couple of seconds or a couple of minutes or during or subsequently following their recreational abuse. And we have to understand that when we're around people and we're engaged in such behaviors, how quickly will someone have the wherewithal intellectually or just be aware to say, you know what, forget about what we have here, whether that be illicit chemicals, whether that be weapons, or whatever we're involved in. Let's put this person's well-being, let's put this person's life to the forefront. Let that be the priority. Let's notify emergency responders as quickly as possible to get this person some help. I've throughout my career, I've worked with people who've dealt with this. They were sitting around and they spoke about, and I'm just paraphrasing collectively, so please bear with me. They were sitting around smoking what they thought was just marijuana. They had no intentions on intentionally purchasing anything that was chemically modified. They did not request it. They did not demand it. They did not inquire about it. They just purchased what they thought was cannabis, just to smoke, to go through that brief euphoria or the mild euphoria that they were expecting. But come to find out, they were engaging in something that was synthetic from a tetrahydrocannabinol perspective. And one person or even multiple people at the same time had adverse reactions and they needed immediate medical attention. So in this particular case, I'll ask, according to your memory, the best that you can recall as far as what took place, how quickly did we call the emergency responders? And the answers are normally pretty similar. There's always, while this person's going through their adverse reactions, potentially losing their life, there's always conversations about what will happen to us if the police show up here or if paramedics show up and they were to see drug paraphernalia. They were to see other forms of other chemicals around. They were to see unregistered weapons. They were to see stolen property. So while these conversations are being had, we have to understand in any medical situation, any emergency situation, all time matters. Even a few seconds could be the difference between saving a person's life and a person passing away. So I'd like for us to keep that in mind, whether it's ourselves or we're working with others. When we're consuming any product, we have to ask ourselves, has it been modified? Is what I'm getting natural? Is it synthetic? Is this what I've asked for? We just have to keep that in mind. And when it comes to any form of cannabinoid, in this case marijuana, I'll ask the person if they grew it themselves. And very rarely will someone say yes. In most cases, the answer is no. So in this particular case, you didn't grow it yourself, so you were not around in the origin of the particular substance. So then I'll ask the rhetorical question, who handled it and what did they do to it? And obviously we have no idea who handled it, where it's been, what's been done to it, because we were not there from the origin. And I always tell people that for whatever reasons, drug dealers throughout the United States of America and perhaps throughout the world are taking it to their own hands as far as modifying chemicals or supplying chemicals that and not just drug dealers, drug traffickers. They're supplying product that have not been asked for by the particular purchaser, and they have no idea of what kind of reaction this individual's body or central nervous system or whatever. They have no idea how this person's body going to respond. And under these situations, I pretty much dive into, will this person genuinely care unconditionally if they receive word or some form of notification that, hey, a product you sold took someone's life. Now, they may care as far as their own well-being, what's going to happen to me. Well, could this get traced back to me? Could I end up facing the criminal justice system? If they're spiritual, they could even find themselves asking themselves, could this be something I have to answer for when it comes to meeting my higher power? But under these circumstances, I'd just like to point out the unfortunate realization that traffickers / dealers may not wholeheartedly or even at all care about what happened to the particular person if there is some form of adverse reaction. At this point in the presentation, I would like to shift towards cannabis dependence as it correlates with cannabis use disorders. People meeting with the diagnosing criteria for cannabis dependence have compulsive use and generally develop psychological or even iatrogenic dependence upon cannabis. It is not an extraordinary occurrence for such people to manufacture tolerance to the vast majority of the effects of cannabis, whether that be dissociation, depersonalization, derealization, or even hallucination. People with cannabis dependence may misappropriate immensely potent cannabis throughout the day, and this is something that could last for weeks, months, or perhaps years at a time, depending on the severity and the extent of their cannabis use or abuse. Remaining focused on cannabis dependence, abusers may have issues dedicating significant amounts of hours throughout each day just geared towards acquiring and ultimately abusing cannabis. This could also include activities to acquire the monetary means to engage in cannabis abuse because of their level of dependence. These sorts of endeavors could impede upon family, educational, vocational, occupational, and even recreational endeavors and obligations. There was a point not too long ago in my career I was facilitating a group counseling session. I was providing a hypothetical scenario after I explained the concepts related to driving under the influence. This particular group, they were under the impression that driving under the influence, as far as being an arrestable offense, they were under the impression that that was just allocated towards alcohol related occurrences. I shared with the group, I mentioned to them that driving under the influence means operating an automobile while under the influence of any mind altering chemical, not just alcohol. And I was focused on marijuana / cannabis. I shared with the group members during this counseling session, I spoke of if you were at a gathering socially and you were abusing cannabis and you elected to get behind the wheel of an automobile, you fall under the same criteria criminologically as if you were operating that same automobile after consuming beer, wine, or spirits, or some form of alcohol. I shared with the group, I said, let's just say you were involved in some sort of motor vehicle accident and you survived the accident, but you unfortunately had to be life flighted to for emergency services because of the severity of the accident resulting in you losing a significant amount of blood. We have to be under the impression that under these conditions, medical personnel may not know your blood type automatically, and now you're in a position where you may need a transfusion. So under these circumstances, they have to get your blood type. And we also have to keep in mind that there may be proceedings in place in which they may have to run your blood through toxicology proceedings. So upon learning your blood type, we'll say hypothetically the blood type is A positive. They also find out that this individual may not have an elevated blood alcohol concentration above an unlawful level, but this person has elevated levels of tetrahydrocannabinol, meaning they've been engaged in some form of substance abuse. Now I want to disregard, which I'm going to dive into a little later in this presentation, I want to disregard this person having a prescription for some sort of anxiety-related mental health challenge or some sort of matters dealing with post-traumatic stress disorder symptoms and things of that nature. I just want to focus on this person was at a party, they engaged in illicit marijuana abuse, and ultimately got behind the wheel of an automobile. And after all this all took place, this individual was found, because of their toxicology report, it was proven that they had elevated nanogram per milliliter levels of tetrahydrocannabinol in their system. And also, in addition to this particular occurrence, this particular motor vehicle accident, one of the other motorists under these conditions, they unfortunately lost their lives. So now this person who was involved in this accident, even if they weren't the ones who perpetrated or who caused the accident, they are now potentially going to be dealing with possible manslaughter charges, and they could be facing an immense amount of time in state prison, all because, not because of the accident. Unfortunately, accidents happen and fatalities happen on roads and highways throughout the world. But now this goes from being an unfortunate accident to now being an issue that's going to be dealt with by the criminal justice system. I like to encourage people, whether it's during individual, group, or family counseling sessions, when we're focused on not just cannabis, but any mind-altering substance, even if we're prescribed it. I like for us to be very cognizant of what we have in our system before we decide to get behind the wheel of an automobile, because of what could happen, whether it be a mistake or some sort of indecision, any form of the abuse of a mind-altering chemical, and in this case, cannabis, could result in us spending a significant amount of time in state prison. We've addressed cannabis dependence and cannabis abuse. This is where I would like to briefly transition into cannabis intoxication or inebriation regarding cannabis use disorder diagnoses. The essential feature of cannabis intoxication is the presence of clinically significant maladaptive behavioral or psychological modifications that present themselves during or shortly after abusing marijuana. Cannabis intoxication customarily commences with a sense of euphoria, and this euphoria could manifest itself from the perspective of dissociation, derealization, as well as depersonalization. Remaining on the subject of cannabis-related inebriation, occasionally anxiety-related implications or social withdrawal occurs. These psychoactive effects are accompanied by an increased appetite, the drying of the mouth, which is synonymous with substance abuse, and is reasoning for the losing of the teeth, which I may perhaps address later in a different presentation, and the need to fall asleep. Inebriation or intoxication, as far as cannabis abuse, develops within minutes if marijuana is smoked, but may take a few hours to develop if ingested orally. The effects generally last roughly 3 to 4 hours, with the duration lasting longer if the substance is consumed orally. With cannabinoids being fat soluble, the effects of cannabis may occasionally persist or reoccur for 12 to 24 hours. Now, this is where I want to transition into a concept referred to as pulsation. And please bear with me. We're speaking of an individual with, hypothetically, a cannabis use disorder severe diagnosis with immense dependence. So this person abuses cannabis habitually throughout the day if they could, monetarily and things of that nature. This is something that dominates their life. Now, this particular person, their body is going to be conditioned to function with elevated levels, elevated nanogram per milliliter levels of tetrahydrocannabinol. And here's where I'm going. Let's say, hypothetically, this persists for roughly a decade. This individual decides to no longer engage in not only cannabis abuse, but any form of substance abuse, including cigarette smoking or chain smoking. So let's just say, hypothetically, it's been roughly 9 months. Now, since this person engaged in any form of cannabis abuse, unfortunately, because of problems that took place during active addiction, this person has obligations to fulfill with the criminal justice system, which includes taking part in urine screenings or urine analyses. This individual, after 9 months of not engaging in any form of substance abuse, because of pulsation or conditioning through pulsation, this person produces a positive urine screen that ascertains recent cannabis abuse, which is depicted by their elevated levels of tetrahydrocannabinol as far as nanograms per milliliter. Now, this person is confused, this person is concerned, this person is convinced that they didn't do anything wrong, and actually they didn't. In all actuality, this person has not engaged in any form of substance abuse, like I mentioned, in 9 months. But now it's the question scientifically, how do we produce a positive urine screen as far as elevated nanogram levels of tetrahydrocannabinol? So this urine screening kit, which was done in a cup in his, we'll say, probation officer's office. So this person is saying, hey, that there's some sort of error that's taking place. This person is questioning the legitimacy of the cup. This person is questioning if the kit is expired, if it's been stored inappropriately, if it's been tainted in some manner, or something along those lines. So the probation officer says it's okay. We have processes in place for this. They're going to take that same sample and they're going to send it off to a laboratory. Now the client is saying, well, I'm a little bit concerned about that sample being tainted as far as if there's something wrong with that particular kit or that cup. Could that have bearing on the results of the laboratory examination? This person is allowed to provide another urine sample inside of a different cup, and it's been proven that this particular cup is fresh out of a batch. It hasn't been tainted with, it's not expired. This person is comfortable to put their urine sample in that particular cup or that particular form of collection, have it sent off to a laboratory. The results come back from a laboratory, same thing, elevated tetrahydrocannabinol, elevated nanogram levels per milliliter. So this person is barely above the positive threshold, but well, in this case, it's negative for the client. But pretty much this person produced a positive urine screen for elevated levels of tetrahydrocannabinol. So this person is trying to figure out what's taking place. What happened here is, because of their extensive history of cannabis abuse, cannabis dependence, and their cannabis use disorder severe, and now in this case, because they have documented substantiation of at least 90 days of cannabis-related sobriety, they have what's called a cannabis use disorder severe in early remission diagnosis. So now this in early remission diagnosis is being questioned as far as going away because of the elevated levels of tetrahydrocannabinol. Now this person is confused. They're feeling as though that the criminal justice system is out to get them because of this positive urine screen. What potentially took place is conditioning through, what potentially took place is pulsation. what happened here is this person is their their body has become so accustomed to having elevated levels of tetrahydrocannabinol. Pulsation through conditioning took place. I mentioned earlier in this presentation that the human body naturally produces small nanogram per milliliter counts of tetrahydrocannabinol. So this person's body, during their period of cannabis-related active addiction, let's just say hypothetically, their body has been functioning or conditioned to function with, we'll say in this case, 1,200 nanograms per milliliter as far as tetrahydrocannabinol. So even with their sustained, prolonged cannabis-related abstinence, pulsation took place, so their body produced a little more than what it would have if they didn't have to be concerned about elevated tetrahydrocannabinol levels that took place during active addiction. So now we'll say in this particular case, the probation officer, they're testing for, and their threshold as far as a positive urine screen is 150 nanograms of tetrahydrocannabinol. This person produced a urine screen, we'll just say here, is barely above. It's at about 175 nanograms. So naturally, the human body does not generally produce that much. So what this says here is this person must have recently ingested or consumed a very small amount. Now going back to cannabis use disorders, this person has a cannabis use disorder severe diagnosis. Well, in this case, this person at least still has a cannabis use disorder severe in early remission diagnosis, and that's being questioned at this particular time. Their multi-systemic team is going to come together, but that's a different subject for a different time. What's happening here is, and the question here is, with their history of cannabis abuse, could this person neurologically be in a position to just consume such a small quantity to have their tetrahydrocannabinol nanogram per milliliter levels just be barely above the positive threshold of 175 nanograms per milliliter? So the concern there is, okay, did this person engage in a small amount? Is this a recent consumption or ingestion? Or scientifically, is this pulsation that took place through conditioning, going back to this person having a sustained history of cannabis abuse that extended a 10-year period? When it comes to a cannabis use disorder severe and early remission diagnosis, or whatever the specification or specifier is, generally a cannabis use disorder related diagnosis is not going to sit by itself, whether that's the primary diagnosis, secondary, tertiary, or supplementary diagnosis. Someone presenting with a cannabis use disorder related diagnosis will usually have an additional diagnosis or additional diagnoses, including mental health related diagnoses or psychiatric or psychological related diagnoses that will accompany this individual as far as treatment planning and things of that nature. Because of that, that's why practitioners should elect to implement cross-addiction related concepts to treatment planning. I do have another presentation that dives a little deeper into cross-addiction and treatment planning related matters. Feel free to look into that particular presentation that I have on my channel. Cannabis is traditionally misappropriated with additional substances or chemical groupings such as alcohol, opioids, and central nervous system psychostimulants, to mention a few. Cannabis is usually smoked or inhaled, which we discussed earlier in this presentation, and may be mixed with opioids such as heroin or hallucinogens such as phencyclidine. I spoke of earlier in this presentation about someone or people just in general feeling as though they've reached out to their supplier, so to speak, and they were under the impression they were just purchasing and using or abusing marijuana or cannabis by itself. But things happen along the lines, and come to find out this individual They were actually they had some form of opioids, so we'll just say heroin, or some form of central nervous system psychostimulant, so we'll just say cocaine here, in their marijuana. Well, what happened here, and I've seen this unfortunately countless times throughout my career, I'll have someone share with me that they've been experiencing, they'll disclose during an individual counseling session that they've been experiencing withdrawal related symptoms that they're not accustomed to. And I'll dive into things and address what took place. And I'll say that does not sound like what they're mentioning, do not sound like withdrawal related symptoms that correspond with cannabis related withdrawals. I'll say something along the lines of there could have been some form of contamination that took place with your marijuana. And that's what I'll dive into, and I'll use this for what's called counter conditioning purposes. I'll say this is why we have to be very aware of what we're doing, because we have no idea what we're ingesting into our bodies until it's too late. There's been numerous occasions throughout my career I've literally received emergency notifications from probation or parole officers' offices, and I've had someone who presented with some sort of cannabis use disorder diagnosis, and we'll just say here hypothetically a cannabis use disorder moderate diagnosis, and I'll submit documentation showing the and advocate for the client, showing the great work we're doing. And yes, we do have this clinical diagnosis here, and we're working on reducing features of that particular diagnosis. Under those circumstances, I've worked with some great practitioners from different disciplines and different organizations, and they're understanding that this is a methodical process, and they recognize that we just can't say, you better produce a negative urine screen or else, as far as reprimanding. So we produced multiple urine screens. They're just showing recent abuse as far as cannabis. But then all of a sudden, this person, and we're working on that, but then all of a sudden, this person produces a positive urine screen for hallucinogens, barbiturates, central nervous system stimulants, and things of that nature. So now the question here is, okay, what's taking place here? And I'll speak with my client telephonically or through some form of privacy-approved teleconferencing alternative. And I like to do this in this situation. I want to look at my client's eyes. I want to see their facial expression. I want to look at their body language. And I've always felt as though I've had great rapport with my clients, and clients have told me great stories and wonderful things happening in their lives, and I've been told some not so great stories. And I've always taken great pride in that I've been able to establish rapport and trust and build that professional relationship to a point where we can just be wholeheartedly honest with each other as far as the good, the bad, and the ugly. And the client will say, Dr. Curry, you know that I just smoke marijuana. I have no idea what those other chemicals are. I have no idea how they got into my urine screen, but we have this urine test being positive for this, that, and this, and that. So that's what I would dive into. Okay, let's walk back. What took place? When was the last time we engaged in marijuana abuse? They'll say hypothetically, 2 nights ago, I was at a party on a college campus. So I'll say, okay, this is making sense. Have we gone to this particular college campus before? The client will say no. I say, okay, the marijuana that you had, did you bring it yourself, or did the people you were with that you generally engage in marijuana abuse with, did they bring it themselves? And the person will say, under these circumstances, they'll say, no, actually it was available at the college campus. I just purchased it there and went about my business as far as partying and engaging in cannabis abuse. So that's when I'll dive into, okay, so you're telling myself that you're a criminal justice practitioner and their supervisor and the rest of the team, your multi-systemic team and your advocacy support team. You're telling me that you went to a college campus that you've never gone to before, you've partied with people that you've never been around before, and you purchased illicit substances from people that you never dealt with from this perspective before. So now we're at least providing some sort of clarification, and that's when I'll dive back into, we have to be extremely careful with not only who we engage with, but what we introduce to our bodies. Because you went to this this party on this college campus, assuming that you're just going to smoke marijuana. So now we're in a position where your criminal justice practitioner, your probation slash parole officer is questioning your actual commitment to programming, because we were under the impression, at least programmatically, that we're working towards diminishing features of your cannabis use disorder related diagnosis. But now we're producing a urine screening, a positive urine screening for other chemicals that were not problematical in the past. And under these conditions, I like to at least work with the criminal justice practitioners, work with the client, and just ask for a favor and just say, hey, could we at least give the client a chance to be taken as though that what they're saying is the truth, and just come back and address these matters subsequently. And this is where they're generally an agreement is made that, okay, we're going to allow sufficient time for those particular chemicals to come out of the client's system. They'll produce a urine sample at a predetermined date to at least give the client a chance to get those particular chemicals out of their system. Ultimately, the goal here isn't not necessarily to produce a negative urine screening, which ultimately is the goal, but it's just to make sure that what the client said, the story that the client said, is in fact what took place, and then we can return back to programmatic considerations and just chop that experience up to just indecision making and poor choices.
In addition to cross-addiction related considerations, when it comes to cannabis abuse, approximately 1/3 of individuals presenting with features of a cannabis use disorder diagnosis could present with features of a persistent depressive disorder diagnosis, a generalized anxiety disorder diagnosis, or some other psychiatric or personality disorder diagnosis. For case consultation purposes, I would like to present a 27-year-old African American male presenting with a cannabis use disorder severe diagnosis. This person has current involvement with Child Protective Services as well as the criminal justice system. This person has spent roughly 15 years combined time out of his life in county and state correctional facilities. This individual, with his cannabis use disorder severe diagnosis, he's illustrated severe dependence and severe abuse throughout his challenges with active addiction. I'm working with this person, and this is a hypothetical person, so this is not an actual client that I have or I am currently working with. This person is reporting to me that depending on circumstances, depending on monetary considerations, he is smoking approximately 5 total marijuana blunts per day. Now, he does have active involvement, like I mentioned, with Child Protective Services and the criminal justice system. He's being obligated to present urine screenings, to have involvement with drug screenings consistently with both of these entities. What I would do under these circumstances, I would work with each practitioner from Child Protective Services as well as the criminal justice system. From a clinical perspective, I will be the one spearheading what's going on programmatically as far as helping the team collectively understand substance use disorder diagnoses. It'll be my job to help everyone know that, of course, the ultimate goal is to progress towards sustained active recovery and to put cannabis abuse in its past. I will talk to them about, of course, with his permission, we will go through confidentiality, what can and cannot be shared, and what he will allow me to share, depending on what's taking place. But under these circumstances, let's just say that he gave me the okay to let them know that what he disclosed to me is that pretty much he's consuming, he's smoking about 5 total marijuana blunts each day. I would tell the team, after working with him collaboratively, I would say my goal here, because realistically, and I'm not saying that it cannot be done, people have shared with me, but they have gone cold turkey instantaneously. But for the most part, I at least like to address clients as though going cold turkey is not a realistic goal for us. If a person's able to do it, then that's wonderful. They're making my job easier and making their lives easier. So in this case, let's just say this individual is not going to be able to go cold turkey as far as putting marijuana abuse in his past. So with him telling me that he's smoking approximately 5 marijuana blunts per day, what I would do in this particular situation, I would work with the client. I would say, what my goal here is, first, I would like us to at least understand what we're doing. So in this case, he's already quantified for me that he is smoking 5 marijuana blunts a day. I'll look at my calendar. I would say, okay, today is February 4th, 2021. My goal here is I want us to come up with a plan. First of all, psychologically, we're going to start gradually reducing the amount of cannabis we abuse starting March 1st. We've already got everything on the table as far as his involvement with Child Protective Services, his engagement with the criminal justice system, and other ways substance abuse impacted his life negatively. I work the client. I would say my goal here is, okay, we're going up to 5 marijuana blunts a day starting March 1st. At the beginning of the month, I would like for us to do everything we can to reduce that by 1/2 of a marijuana blunt per day. So starting March 1st, our goal here is to not exceed 4.5 or 4.5 blunts per day. So what we're doing here is we're going to gradually reduce his tetrahydrocannabinol nanogram per milliliter metric count gradually. So my goal there is to not shock his body. And also what we're doing here is we're methodically taking away the amount of marijuana being abused. So the goal there is, no matter what, we're not going to exceed 4.5 marijuana blunts in a given day. If for some reason he exceeds that, I would like for him to reach out to me, or at least share it during our next individual counseling session. Let's go over what happened on that day or during those days, and let's come up with a game plan collectively to see what could we do differently if those same circumstances were to reappear or present themselves subsequently. If for some reason he's able to not come close to the 4.5 or fall short of the 4.5, we're going to make that, we're going to celebrate that, and the next day we're going to try to do the same thing. I will make sure the client knows that the rule there is, just because, let's say hypothetically, on this given day, he only smoked 2 marijuana blunts. So the rule there is we're not going to be allowed to roll over the 2.5 marijuana blunts into the next day. No matter what's going on, good or bad, we will not exceed 4.5, and that's as of March. Come the following month, come April, what we're doing there is we're going to take away another 1/2 of a marijuana blunt. So come April 1st, the goal there is to not exceed 4 marijuana blunts in a given day as far as smoking. Come May 1st, the goal there is to drop that down to 3.5. So what we're doing there, we're setting specific, measurable, attainable, relevant, and time-bound. SMART. That's the acronym for SMART. We're setting those particular SMART goals. We're setting short-term, achievable goals that the individual is going to be able to accomplish. What this is doing here is we're gradually accomplishing goals. His confidence is rising. He's going to become more engaged in treatment. And if there's cross-addiction related considerations, we're also going to keep those in mind as well while we're addressing other substance use disorder diagnoses. I'm still going to, as the months passing by and as the amount of marijuana blunts are diminishing, we're still implementing behavioral health medication management programming if applicable, medication assisted treatment programming if applicable. I'm persisting with providing psychoeducation pertaining to cannabinoids and his cannabis use disorder diagnosis, including cross-addiction related considerations if applicable. We're involved with Narcotics Anonymous meetings if he's willing to. We're engaged with group counseling sessions if he's willing to. We're including family and friends if he and if they are willing to. So all of this is being used collectively in conjunction to help him reduce features of his cannabis use disorder severe diagnosis. Continuing with the client that was presented during case consultations with the cannabis use disorder severe diagnosis. I'll review notes, I'll review previous individual counseling sessions, and I'll dive back into him disclosing occurrences related to paranoid related ideations. I'll discuss about him previously mentioning experiencing dissociation, depersonalization, and derealization. So I'll ask him, with things changing, with us progressing, with us advancing programmatically, and him taking those steps towards sustained active recovery, I'll talk to him about what he experienced when he was separated from himself, when he was separated from reality. And what I'll do there is I'll take notes and I'll document what he says during this session, and I'll compare them to previous sessions. I'll see if the stories are at least matching. I'll see if they're at different ends of the spectrum. The ultimate goal there is to use that psychoeducation to further discuss dissociation, to further discuss depersonalization and derealization, and essentially the disengagement from what's taking place in actuality. I'll use that psychoeducation there. I'll implement cognitive behavioral therapy. The point there is I'm reminding us to let's think of worst case scenarios before we engage in decision making. Let's use that imagery to visualize what could take place. And I'll talk to them. I'll see, even though we're here in my office or wherever we're at from a clinical services perspective, I'll say we're here, we're going through the criminal justice system, we're going through child protective services. We are free, and we at least have a chance to put all of these things behind us in a positive way. But I'll use all of those experiences for counter-conditioning purposes. And I'll remind the client that diving back into cannabis abuse could reopen these proverbial cans of worms. And this time around, if there is a next time, this particular time around, things could be much worse, especially when we're dealing with dissociation, depersonalization, and derealization. Ultimately, from an awareness perspective, we're separated from reality. We may or may not have wholehearted control over our decision making, over what's taking place because of these mind altering chemicals. And like I mentioned earlier in this presentation and during other presentations, just because mind altering chemicals are impacting our decision making and our behavior, we are still ultimately accountable for what does or does not take place. Whether I'm dealing with a client who has involvement with the criminal justice system or child protective services, or even both at the same time, or I'm dealing with a client who is just reporting to treatment to just work towards reducing features of their cannabis use disorder related diagnosis or co-occurring disorder related diagnoses, I'll use a lot of psychoeducation, and part of the psychoeducation I'll discuss medicinal or medical considerations. Remaining focused on just cannabis abuse, I'll oftentimes ask someone, I'll say, from your perspective, from a medical standpoint, how is your life being impacted through cannabis abuse? And I'll oftentimes hear stories about how about medical marijuana. And like I mentioned earlier in this presentation, I am a huge advocate of any form of behavioral health medication management programming or medication assisted treatment programming, or anything that involves utilizing chemicals for medicinal purposes. So whenever I hear that, I'll say, yes, I do agree there are medical purposes for cannabis. And that's been proven going back to the 1980s. And the medical community scientifically has only advanced. So we're finding more and more medicinal purposes for cannabis, whether that be for medical reasonings, for psychiatric reasonings, or a combination of both. But what I'll do here is I'll say you have to understand that going back to tetrahydrocannabinol and cleansing and scientific purification, I'll say you have to understand that what medical doctors are using and what they're prescribing, that's different than what's being purchased from the streets. So I remind clients that whatever you may be purchasing, let's just say from a housing area a few blocks or a few miles away from your home, That's not the same product from a chemical compound perspective that you would be received going through prescription proceedings, going through a clinical medical process to just focus on a specific medical or mental health related diagnosis. So I'll use those concepts to help a client come to the realization that what's being purchased off the streets, despite scientific research ascertaining there are proven medical purposes for cannabis, what's being purchased from the streets is completely different from a compound perspective than what a medical doctor would prescribe. Cross-culturally and sociologically, when it comes to starting a path towards active addiction, a lot of people, especially in the United States of America, their introduction to substance abuse starts with cannabis. I've worked with a lot of adolescents throughout my career, unfortunately too many to even quantify. And they've shared stories about whether that be from walking to school or during school or just being in the community or unfortunately even engaging in substance abuse with adults, with relatives. They've spoken about being introduced to substance abuse through cannabis. Some have shared with me that they've used cannabis for self-medication purposes. I've worked with countless clients who were adolescents, at least at the time, who dealt with some form of insomnia or some form of sleep-related issue. And they'll share with me, they'll say, Dr. Curry, I only smoke marijuana to help me sleep. I get to sleep. I wake up, particularly during the school year, I get a decent night's sleep. I wake up, I have breakfast, I go to school, I get good grades. I get perfect grades. I have all A's for consecutive report periods for consecutive years. I'm on path to get a college scholarship. I'm on path to get offers for academic scholarships to attend, to at least have a chance to attend various universities. So according to what they're sharing from their perspective, them self-medicating with marijuana has been helpful. They're unfortunately oblivious to what could be taking place with their bodies from a health perspective. What I do under those situations, I like to highlight the great job they're doing academically and the focus that they're illustrating by trying to get a good night's sleep rather than staying up late playing video games, rather than engaging on social media, rather than doing something with friends when they should be shutting their bodies down and getting a good night's sleep. So I like to offer to them, I'll say, okay, congratulations on all of that. And that is the ultimate goal. Let's go to school. Let's get the best grades that we can. And let's make sure that we have as many doors open to us as possible. But what I do, I bring things back to the antisocial behavior. I'll remind them that let's talk medically. Since we're talking about self-medication, I'll remind them that even hypothetically, they walk into school or something were to happen where they're approached by law enforcement, and we're not going to dive into the Fourth Amendment of the United States Constitution and searches and seizures under this presentation. But let's just say, for some particular reason, law enforcement, they're obligated to detain you and to search you, and they find prescription Vicodin on you. And they check your identification, and the few tablets that's in that bottle, and there's a name on that prescription, it doesn't match your identification. So now we're facing potential possession charges. We're facing some sort of possible reprimand. I'll talk to them about, since we're speaking medically in the form of cannabis, it's the same thing. We cannot lawfully possess medication that's not prescribed to us. And then I'll dive back into the marijuana that they've purchased and they possess illicitly. Now we're facing potential reprimanding as far as having medication that doesn't belong to us, and also dealing with the realization that the marijuana they purchased illicitly may perhaps have the ingredient delta-9 tetrahydrocannabinol, which induces the euphoria, which doesn't have the medicinal purposes. So what I'll do there is I'll say, let's go and have the proper screenings, let's have the proper assessments from a medical, clinical standpoint. Let's receive an actual diagnosis, and let's go to a physician who prescribes cannabis. And I'll talk to them about there being an assortment of strands of medical marijuana. I'll share with them that a medical doctor may prescribe this particular strand of marijuana for a post-traumatic stress disorder diagnosis, and they may provide another strand to another client who's presenting with insomnia or hypersomnia or some other form of sleep-related issue. A third client may receive an entirely different strand of medical marijuana to treat epilepsy. So I'll tell the client that just like with any medication, medical doctors will do the best they can to get you the proper strain or the proper medication for your distinguished diagnosis. So let's go through those particular steps to get a proper assessment, to get an actual diagnosis, to get a prognosis, and receive the actual strand of marijuana that they may need for their particular ailments. And rather than engage in self-medication, let's get on a medication regimen, and let's reduce features of that specific diagnosis and get a more appropriate prognosis that we're looking for.
Cannabis dependence stemming from cannabis abuse usually develops over a long period of time. Through chronic consumption, there is oftentimes a diminishment of the pleasurable effects of euphoria associated with a specific chemical. This is something that could lead people into the experimentation and subsequent iatrogenic dependence upon other chemicals, which results in cross-addiction related matters.
Earlier, briefly, I spoke about two different categorizations of mental health disorders. Those were both psychotic and personality. What I have here is conduct disorder and antisocial personality disorder. And what I'm doing here is I'm going to correlate those to cannabis use related disorder diagnoses. When it comes to conduct disorder and antisocial personality disorder, those specific disorders deal with behavioral considerations. They ultimately focus on, and as far as this particular presentation, I'm not going to dive too deep into conduct disorder or antisocial personality disorder. But those respective personality disorders essentially focus on an individual who presents with features of them, focus on them illustrating some sort of disregard for societal norms, and this could result in involvement with the criminal justice system. When it comes to cannabis abuse and introducing mind-altering chemicals into someone's symptoms, their behaviors could manifest themselves through features of conduct disorder or antisocial personality disorder. Or flipping things around, someone who presents with features of those respective personality disorders with their disregard for societal norm, they may purposely just engage in some form of substance abuse, whether that be cannabis abuse, cocaine abuse, heroin abuse, methamphetamine abuse, or ultimately polysubstance abuse, or engage in some sort of cross-addiction related matters. Throughout this presentation, I spent a lot of time addressing predominantly cannabis as far as cannabinoids. I've touched on tetrahydrocannabinol. I've addressed cannabis use disorder related diagnoses, including cannabis dependence and cannabis abuse, and we focused on cannabis related inebriation / intoxication. I would like to transition into another cannabinoid referred to as cannabidiol or CBD. Cannabidiol is potentially the second most famous cannabinoid. Similar to tetrahydrocannabinol, the list of medicinal benefits of cannabidiol is increasingly becoming more extensive as the medical community and the scientific community progressively advance. Unlike tetrahydrocannabinol, cannabinol. Cannabidiol is non-psychoactive. With such considerable medicinal purposes, legalization of cannabidiol throughout the vast majority of the United States of America has become much more disproportionate in comparison to its more controversial counterpart, tetrahydrocannabinol. Once mainstream cultural entities learned that cannabidiol had value from a medical, scientific perspective, a whirlwind of cannabis-related research ensued. Epileptic seizures, various forms of cancer, physical pain management, and an array of mental health disorders are just a handful of conditions cannabidiol is used for from a short-term and long-term perspective as far as treatment and rehabilitation. One thing in particular, going back to me mentioning pain management, there's an awareness from a medical perspective that opioids, with them acting as painkillers, those have been used for pain management purposes. And I would like to say, use a hypothetical situation, someone who was involved in, unfortunately, a motorcycle accident. They may go through operations, have their surgeries, and make an effort to return to a life that was as normal as what resembled their life prior to their unfortunate accident. They may go to what's referred to as a pain management clinic and get put on some sort of opioid-related pain management programming. The unfortunate part of that is opioids are very addictive, and someone who didn't have any form of past as far as substance abuse, someone who doesn't even consume any form of alcohol, someone who doesn't even drink socially, someone who doesn't smoke cigarettes, someone who doesn't engage in utilizing chewing tobacco, they're now involved in a pain management regimen through a pain management clinic on some sort of opioid-related treatment programming, and they could be positioning themselves to develop a full-blown opioid-related addiction. When it comes to cannabidiol and other forms of cannabinoids, with them not being, with these sorts of programmings, not having involvement with chemicals that are not psychoactive, that are not nearly as addictive to opioids, cannabidiol and other forms of cannabinoids could be used for pain management purposes to replace someone possibly going against some sort of opioid-related treatment, and ultimately help someone perhaps abstain from engaging in a life centered on opioid-related addiction. Another cannabinoid I would like to introduce to us is cannabichromine, otherwise known as or referred to as CBC. Cannabichromine is the third most commonplace cannabinoid in the cannabis plant overall. In some strains, cannabichromine may even take dominance over cannabidiol. It may perhaps be used by a medical professional under more circumstances. It may be resorted to more oftentimes in comparison to cannabidiol, and of course that varies from practitioner to practitioner, from diagnosis to diagnosis, from individual to individual. Like cannabidiol, cannabichromine is also in fact non-psychoactive.
Cannabichromine also has medicinal purposes. It could be utilized as an anti-inflammatory medication. Cannabichromine is effective at fighting inflammation on its own, but contemporary research has proven that it is even more effective when utilized in conjunction with tetrahydrocannabinol.
A research study conducted in 2013 found that cannabichromine may actually help with the enhancement for supplementary brain cells. Regardless of your age, cells in specific portions of the human brain continue to grow through a process referred to as neurogenesis. The portions affected are responsible for memorization and learning. This is something that I lean upon heavily when I'm dealing with clients in a clinical setting, as far as reducing features of not just their substance use related diagnoses, including their cannabis use disorder diagnosis if they're presenting with characteristics of one, but also their co-occurring disorder considerations as well. Reason being is I like to even if we're incorporating behavioral health medication management programming, medication assisted programming, what I like to do is I like to keep a focus on our ongoing development neurocognitively, intellectually, and maintaining and enhancing where we're at. I like to remind clients that when we engage in substance abuse, or if we're misappropriating prescription medication, or if we're engaging in some form of self-medication, we could be ultimately damaging our enhancement from a neurocognitive, intellectual perspective. So in addition to making it more problematical for us to get smarter, for us to recall, restore, retrieve information through memorization, we could be putting ourselves in a position to make things more challenging from that particular perspective. I use that for counter-conditioning purposes to help the person ultimately help themselves and even help others reduce features of their cannabis use disorder related diagnosis, and also each of their co-occurring disorder diagnoses, if applicable. Early on in this presentation, I made mentioning of eventually addressing delta-8 tetrahydrocannabinol, and I reached that point. Delta-8 tetrahydrocannabinol is slightly different from delta-9 tetrahydrocannabinol. Delta-8 tetrahydrocannabinol is less psychoactive in comparison to delta-9 tetrahydrocannabinol. Researchers have claimed that delta-8 tetrahydrocannabinol may have neuroprotective and anti-anxiety properties, making it an interesting companion in comparison to delta-9 tetrahydrocannabinol, particularly from a neuroprotective, neurocognitive, brain-related perspective. Delta-8 tetrahydrocannabinol is an appetite stimulator, more potent than its delta-9 tetrahydrocannabinol counterpart. It serves medically for anti-nausea treatment. Approximately 8 children with cancer volunteered, of course, through their parents and guardians' support and advocacy, for a distinctive research study in 1995, and were subsequently treated with delta-8 tetrahydrocannabinol during the course of their respective chemotherapy. I've mentioned a couple of times throughout this presentation that the scientific / medical community has been resorting to cannabinoids going back to the 1980s. So as I'm addressing here, this particular research study that was conducted in 1995, where children were being introduced to delta-8 tetrahydrocannabinol, who were unfortunately going through cancer treatment, which included chemotherapy. The results of the research study were baffling significantly. Nausea and vomiting were considerably diminished with each research participant. The delta-8 tetrahydrocannabinol did not produce any psychoactive response in any of the children, each of whom were between the ages of 2 and 13 years old. And like I mentioned, they were going through cancer treatment, which included chemotherapy. I've spoke of synthetic cannabinoids earlier in this presentation, and I've shared that they have been used throughout the years by the medical / scientific community for various forms of treatment. What I like to do with clients, I like to say whether it's a natural cannabinoid, synthetic cannabinoid, delta-8 tetrahydrocannabinol, delta-9 tetrahydrocannabinol, whatever you're engaged in as far as these particular chemicals and these substances, let's make sure that we're remaining cognizant of what this could be doing to us from a psychiatric medical perspective. And this is where I'm going back to or transitioning into synthetic cannabinoids. I recently worked with a client a few years ago, very intelligent client. I felt as though that he had a bright future during our time working together, and I haven't dealt with this client, haven't had any communication with him since successfully completing the program I was involved in. The last that I've heard from him, that he was successfully transitioned back into the community and he was doing well. There was a time during our programming together, he accidentally engaged in some form of synthetic cannabinoid abuse. He was under the impression that he was smoking marijuana that he purchased illicitly. Come to find out, this particular substance that he had his hands on was chemically modified, was altered, was contaminated in some manner. And come to find out, upon testing, he actually engaged in abusing cannabis cyclohexanol. He had an immediate adverse reaction, in which he was transported to the local emergency room. He had a specialist that was brought into the facility to perform surgery on him. When I met with him subsequently, he had shared with me what took place, and he told me that the specialist had informed him that he may perhaps have lost 20 years of his life. He had shared with me that with the amount of additional work that his heart's going to have to do, and this was by the surgeon who told him and his loved ones, and he shared this with me. He informed me that the amount of additional work his heart will do for the rest of his life may have perhaps took off a couple of decades at the end of his life. And I was very sad to hear, just from engaging in a very brief stint of substance abuse, he unintentionally introduced the synthetic cannabinoid of cannabis cyclohexanol into his system, and had to go through that particular surgery because of the adverse reaction his heart had to the cannabis abuse, to the cannabinoid related abuse that he was engaged in. Synthetic cannabinoids are a class of chemicals of which attach to the cannabinoid receptors within the human body. There must be an understanding that they are considerably different from natural cannabinoids found within the cannabis plants. They are habitually marketed as designer chemicals or advertised and distributed as products with declarations that they give the effects of cannabis, or even that they have medical psychiatric benefits. Throughout recent years, I've noticed, perhaps because of their popping up, or perhaps because I'm more attentive of what's taking place, I've noticed a lot of establishments, including gas stations, marketing cannabidiol, cannabicamine, and other cannabinoids. And I'm speaking with clients and I'm speaking with members of the community about what's taking place. And it does get a little bit challenging trying to intellectualize something with someone. And I tell people, when it comes to this type of stuff, I'm not speaking through an opinionated perspective. I'm using proven, research-based information. I'm presenting medical, scientific facts. I'm not sharing my perspective. I at least make an effort to just focus on the science. And I share that with clients all the time. I say, focus on the science. Let's concentrate on what the science is at least showing as of now. And I remind clients, because clients will say that either myself or someone I love, they purchased this from an establishment. And I'll tell them, I said, we have to be mindful that, yes, an establishment, a business, should distribute products that are lawful, but we have to also remind ourselves, are they? Are they governed by the Food and Drug Administration? Are they being regulated by the Drug Enforcement Administration? Are they going through those particular processes? Are they having their products examined? Are they having their procedures addressed from a scientific perspective? Forget about the legality or the criminogenic aspect of things. From a scientific perspective, the product that's being sold isn't in fact what it is. Are they licensed? Even if it is, are they licensed? Are they credentialed to even possess or distribute those particular substances? So I just like to let clients know, just because it's sold at a corner store or a grocery store or some sort of establishment in a plaza for $10, $20 isn't in fact what it is. And are those individuals or are those businesses legally allowed to distribute such product? When synthetic cannabinoid blends initially went into distribution during the earlier years of the 21st century, notion was made that they achieve an effect through a mixture of natural herbs. Laboratory analyses indicated that this was not the case, and that many in fact contain synthetic cannabinoids that act on the human body in a similar way to cannabinoids naturally found in cannabis. A large and complex variety of synthetic cannabinoids, most frequently misappropriated, is cannabis cyclohexanol, which we've addressed throughout this presentation. A few years ago, cannabis cyclohexanol became very prominent as far as individuals who were engaged in various forms of cannabinoid abuse, who had concurrent involvement with the criminal justice system. And here's where I'm going. It was discovered that you can abuse cannabis cyclohexanol but still produce a negative urine screening, which positioned people to not get in trouble as far as urine screens through the criminal justice system. During that particular time, these urine screenings were not detecting the chemically modified cannabis or cannabinoids that individuals were abusing. And I've worked with countless people throughout my career who went through these experiences. So what I would say to them, I would ask them, I would talk about, are we attempting to engage in deception and to produce a negative urine screening? Or are we trying to not just put the criminal justice system in our past, but also put our issues with active addiction in our past? And that's when I would dive into from a chemical compound perspective, because I would say that the reasoning behind why these urine screenings are negative, why you are passing them, is because from a chemical compound perspective, the urine screenings are not detecting elevated levels of delta-9 tetrahydrocannabinol. So that's when I would dive into, okay, under these particular conditions, what are we putting into our bodies from a chemical compound perspective? And I know that they don't have the actual answer. And I would dive into the actuality that is going to take specific people with specific education, predominantly graduate level or postgraduate level, perhaps chemistry-related education, to wholeheartedly or at least somewhat accurately hypothesize or determine what's in chemically modified cannabinoids. What are the long-term effects? I would make those recommendations for people that I worked with to ask those particular questions to themselves. What's going to happen to me in the long run? Will I have physical complications? Will I have neurological complications? Could this potentially be issues that I pass through my genetic pool and pass to my children, grandchildren? Are there going to be generational implications? So these are things I use for counter-conditioning purposes to help people position themselves to come to an understanding that when we're introducing not just natural chemicals in an illicit manner, but synthetic chemicals, we introduce those chemicals into our bodies, what's going to take place? The gentleman I spoke of that I previously provided clinical services for, who had that adverse reaction and was told by a medical practitioner that he perhaps took off a couple of decades from the end of his life because of the amount of supplementary work his heart's going to be doing for the remainder of his life. What are the short-term implications? What's going to happen with us introducing these synthetic chemicals into our body, especially if we're doing it from a long-term perspective? And that's what I would, from an ongoing perspective. And that's what I would just dive into when it comes to cannabis cyclohexanol or some other form of a synthetic cannabinoid or any form of a synthetic chemical or a substance that's been chemically modified. What's going to take place as far as your body, your development, your well-being, and also remaining mindful of generational implications? What's going to happen to you and perhaps generations following because of you engaging in synthetic substance abuse? There was a point in my career I worked with a gentleman who was he purposely engaged in the abuse of cannabis cyclohexanol. This was in a residential setting. What took place was he engaged in this form of cannabinoid abuse, and subsequently he had took off all of his clothes and he just ran down the hallway. No one was injured, no one was hurt, no one was offended. He was subdued pretty quickly. He cooperated, even though he was dissociated from reality. He cooperated, got to a safe area. He was placed in his bed and he went to sleep. He was monitored. Medical personnel was called, but that's not where I was going there. But he was okay. I was told about this story. He had no memory of what took place. The incident only lasted the span of a few minutes, so it wasn't very long. But he had informed me that he had no memory of it. As he was telling me what he was told about his behaviors, his eye contact, his body language, his affect, I was convinced that he had no memory of it. He didn't deny what took place. He had just repeatedly shared that he didn't have any memory of it, and there was a level of concern in his eyes that I saw, that he was really worried about. Okay, this is something serious, especially because of what he was told he had took place in. He had no memories of. And he had gotten to stories about engaging in other forms of cannabinoid abuse and other forms of alcohol-related abuse and substance abuse that he took part in throughout his time in active addiction prior to working with me. And he repeatedly spoke of never experiencing that form of dissociation, that form of depersonalization or derealization, to the degree of not having memory of what took place, doing something that he normally wouldn't have done, such as remove all of his clothing and run down the hallway. So what I did, despite how concerned and how apprehensive he looked, what I did was I took things further. Sometimes in counseling, I have a propensity to take things to deep extremes, and I do this for counter-conditioning purposes. I share with him, under these same circumstances, let's just say you were not in a residential treatment facility where there are security personnel and people supervising you. I share with him, what if you were in an apartment building? What if there wasn't anyone around? What if there were, when I say anyone around, I'm talking about security personnel or people that's in a supervisory position. I share with him and say, what if you were in an apartment building and there were children around? So now we're facing potential child endangerment, sexually related charges with children being around. I spoke of even worse. I said, what if, even though you were under the influence of this mind-altering chemical, I said, what if you attacked one of the children? What if it was something sexually related that you took part in, particularly with you removing off all of your clothing? So what if you attacked someone sexually, particularly a child? Now you're facing an incident that's going to not just lead to you being incarcerated for a long time, not just you living in a state in which sexual offense-related registration lasts the remainder of a person's life, but perhaps most scary, the post-traumatic stress and the psychiatric modifications that particular child, or in this case a victim, could go through because you purposely decided to engage in the abuse of synthetic cannabinoids. There have been assertions made from the medical, scientific fields, respectively, that relative to marijuana, products containing synthetic cannabinoids are measurably different, and the effects are much more unpredictable. That goes back to the circumstances surrounding the two gentlemen I worked with previously, that had the one that had the adverse reaction as far as his heart, and the surgery that subsequently followed, coupled with the news he received about possibly losing a couple of decades off of the end of his life, and the person I just mentioned not too long ago during this presentation whom engaged in cannabis cyclohexanol abuse and ultimately removed his clothing and ran down the hallway. Synthetic cannabinoids are considerably dangerous, since the term synthetic does not apply to the cannabis plant, but rather to the chemical being utilized, and also the modifications and alterations to the particular substance. Research on the safety of synthetic cannabinoids is now being conducted, and as of the production of this presentation, research findings are being published. When it comes to cannabicyclohexanol and additional synthetic cannabinoids, initial research studies have been predominantly concerned with the role of synthetic cannabinoids regarding psychosis. Synthetic cannabinoids may precipitate psychosis, dissociation, depersonalization, and derealization, and in some cases, it could perhaps be prolonged. Research studies suggest that synthetic cannabinoid intoxication is associated with acute psychosis, worsening of previously stable psychotic disorders, and may trigger a chronic, ongoing psychotic disorder or episode among vulnerable individuals. And when it comes to vulnerable individuals, I'm talking about individuals with history, or at least from a genetic perspective, have genetic connections from their gene pool, histories of struggling with not just mental health disorders, but substance use disorder related diagnoses. That brings me to the end of this presentation. We've definitely covered a lot as far as cannabinoids and cannabis use related disorders. We've addressed natural and synthetic cannabinoids. We've spoken about cross-addiction related considerations and steps to move towards sustained active recovery. If you've felt as though that this information was informative and you would like to receive more, please feel free to hit the notification bell so you can be notified when I have some new presentation that's been posted. Please feel free to subscribe to the channel. My intentions are to keep this going, keep things moving forward. We all have very unique, distinguishing experiences, whether we experience them ourselves directly or through the experiences, through the lived experience, the experiences of others. We all have knowledge from whether that be studying or from what we've endured throughout our lives that we could bring to the table to ultimately help someone move towards sustained active recovery and to put antisocial, deviant, troubling ways in their past. Thanks again for taking part in this presentation, and I'll be back again soon.